All right, guys, we have a fantastic video today. I'm super excited to be joined by Phillipe Pibarot. Phillipe is one of the world's foremost experts in echocardiography. He's head of research at the Quebec Heart and Lung Institute, and he's taken time out of his day today to share a critical reappraisal of the SMART trial. We're also joined by Andre Pop, our moderator on the Optimized TAVR channel. Andre's head of structural heart at Alexian Brothers and just a fantastic TAVR operator and a friend. And so, this trial's created a lot of controversy. I think a lot of TAVR operators out there are curious how to digest this trial and apply it to their practice. And we've got no one better than Phillipe Pibarot to walk us through it. So Phillipe, thank you for joining us today, buddy. Appreciate it.
Thank you so much for having me. Just to refresh our memory, this is the design of the SMART trial. So it's a TAVR with the balloon expandable versus the self-expanding valve, but in the context of the small annulus. And this is an important point, the small annulus in the SMART trial was defined as an aortic annulus area less than 430. And one of the interesting points also to discuss is that there were two primary endpoints in this trial. One clinical, okay? So mortality, stroke, and heart failure hospitalization at 1 year, the classical clinical endpoint that we use often for TAVI. But the second co-primary endpoint was bioprosthetic valve dysfunction, BVD. That was defined as a composite of many things, but there was hemodynamic structural valve deterioration. I repeat, hemodynamic structural valve deterioration, but this was defined as a mean gradient by echo, more than 20 millimeters of mercury. And at any echo, it could be at the 30-day echo or the 1 year echo, okay? And then you have non-structural valve dysfunction that we call NSVD that include severe mismatch and or moderate or severe paravalvular. And then there was valve thrombosis, valve endocarditis, and aortic valve intervention. So it's a composite of many things. Just to summarize the key results of the SMART trial to set up the table. So for the primary endpoint, number one, the clinical, there was really no difference in the clinical outcome. So mortality, stroke, rehospitalization. But for the second endpoint, that was the bioprosthetic valve dysfunction endpoint, there was fourfold more higher rate of bioprosthetic valve dysfunction in balloon expandable versus self-expanding. And so there was some higher residual gradient, smaller effective orifice areas, and more severe mismatch in the balloon expandable versus self-expanding. And I think in this context, it is interesting to look at the results of the OPERA TAVI registry. So the OPERA TAVI, the advantage of the OPERA TAVI, it's really a real life, real practice registry, a bit like a TVT registry, but smaller. It's international, multi-center. And they did an analysis, a super-analysis in a small annuli patient using exactly the same definition as SMART, so 430, and they published this paper 2 weeks before the SMART, okay? And actually found, if you focus on the bottom right panel, actually found, again, some more high residual gradient, so mean gradient more than 20 in balloon expandable versus self-expanding, numerically also higher severe mismatch. But in counterpart, they found more moderate or severe paravalvular leak in self-expanding versus balloon expandable. And I mean, so they found more moderate or severe paravalvular leak in the self-expanding versus balloon expandable, which is, what is reported by most studies that did a comparison of balloon expandable versus self-expanding before. Of course, it's not randomized here, it's propensity score match, but interesting though. And for clinical outcomes, well, there was no difference between balloon expandable versus self-expanding, maybe numerically higher rate of events in the self-expanding, which was essentially due to the fact that the self-expanding had more stroke than the balloon expandable, okay? So this is real practice. But then when you compare the two, you realize that there are some intriguing differences. So again, the two, the OPERA TAVI and the SMART shows the more mismatch, high residual gradient in balloon expandable versus self-expanding, which is, typical. But on the other end, the OPERA TAVI shows much more mild and more PVL in the self-expanding. You see 48.5% versus 18.6%. But this is not only moderate and severe, this also include mild. And surprisingly, in the SMART, this is the opposite. And that's the first study comparing the two platforms where I see actually more PVL with the balloon expandable versus the self-expanding. So we'll try to explain this finding later. On the other end, there was more pacemaker in self-expanding versus balloon expandable, both in OPERA TAVI and SMART. This is also, a classical finding that we see. And now where it's getting interesting is in the distribution of the valve size. You see that in the SMART, there was about 1/3 of the patient in the self-expanding arm that had a large valve, a size 29, which is kind of intriguing for a small annulus population. There was also some large valve in OPERA TAVI in the self-expanding, but to a smaller proportion. And on the other end, there was very few patients with let's say, a larger valve, so a 26 for the balloon expandable in the balloon expandable arm in both the OPERA TAVI and SMART. They say, why is this? Look at this, and this is very important chart here. You have here the sizing algorithm, and the definition, again, in SMART for the annulus, the small annulus, is not the one that has been used in the past that was generally used. Generally, a small annulus, until SMART, was defined as a annulus area of less than 400. Some study have used 410, but this one used a somewhat larger, 430, which is small, but not that small, right? And by doing so, you see it has important implication, because if you are 430, you allow for the use of a 29 millimeter valve in the self-expanding arm. Whereas if you are 400 or 430, you could not use this valve, this larger valve. Whereas in the balloon expandable valve, even with this larger cut point of 430, you're still you're precluding the use of the larger valve. So meaning that in one arm, the interventionalist could use 3 sizes, including the larger one, and that's for the self-expanding. They were allowed to use the 23, the 26, or the 29, whereas in the balloon expandable valve, there was only 2 valve size allowed, and they could not use the 26 millimeter. So this is kind of, creating an imbalance in the sizing distribution between the two arms, first thing. And one thing when we have a randomized trial that is absolutely critical, especially when we compare 2 very different platforms that have different technical issues and learning experience, is the selection of the sites. Because otherwise this may introduce a bias into the results. And in SMART, 60% of the patients were treated outside the US, okay? And the high enrolling sites, and there were some very high enrolling sites, showed actually a disproportionate prior experience with the self-expanding and much less experience with the balloon expandable. So I think this is maybe one reason, or the main reason, that could explain this unexpected higher rates of paravalvular leak in the balloon expandable than in the self-expanding. That is really off, and it's not really well explained. And also this higher cut points of 430, as mentioned, kind of created maybe a distortion in the sizing, with about 1/3 of the self-expanding patient who were actually receiving a larger valve. Whereas in the balloon expandable, there were actually almost 0 patients, 1.9% were able to get the 26, the higher size. So I don't know if you want to start here and we discuss it a little bit, because there are other issues, but regarding especially the statistics that are more maybe difficult to digest, but yeah.
No, I think that's compelling stuff, Phillipe. I think it is a little bit conspicuous they chose 430 as the cutoff, which happens to be the tweener between a 23 and a 26 balloon expandable valve, which most people these days are undersizing and overinflating. And I think it really resonated with me, your point on the enrolling centers being high Evolut implanters, because we do know there's a learning curve for Evolut. And if you're only doing 10, 20 Evoluts a year and choosing small annulus patients, you're not going to get as good a data. You're not going to get as good as outcomes. And there's data to support this. And in my own personal experience, we've got great outcomes with Sapien, and when we try to use an evolute, things just, the mojo's off and it just doesn't go as well. So I don't know, Andre, what do you think about the data Phillipe presented so far?
Well, so I think, I try not to blame people for the size of valve that they implant. I am nervous about putting big valves in small annuli, and I think traditionally, Medtronic has put the biggest valve you can in there,
Yeah.
and I think the problem is when you're in between sizes and you put the bigger valve, those are also the valves that I see failing earlier because they are underexpanded. And the only situation where you increase the disparity between balloon expandable and self-expanding is in annuli that are not circular. In the more flat the annulus is, the more ovoidal or the annulus is, the more elongated it is. Your perimeter stays the same, but area decreases. Um, I think that I don't honestly blame them for putting the larger valves in there. I will be curious to see what the outcomes are at 4 and 5 years, because my suspicion is that the more you oversize, the more trouble you potentially get into. And as my strategy has always to put smaller valves and overexpand them and stretch them as much as possible to make sure that they're fully expanded, rather than putting a larger valve minus 1 cc or something, because that doesn't allow for full expansion, and it may compromise leaflet functionality and durability.
Yep. And I do think it's worth mentioning that even though most operators in this trial were very facile with self-expanding valves, there were still 4 embolizations in the core valve group. And, I think that's a common experience is you try to oversize an evolute in a small annulus and it pops out, and I think
Well,
especially when you're implanting it high, as current operators are, that risk is a lot higher. So,
yeah, and I think one of two things that stood out to me were one, as Phillipe indicated, the numbers that we're seeing are not really consistent with the other published literature. But the second thing is, this trial used very high implants on the Medtronic side. It doesn't clearly say what it did on the Sapien side. But the classic expectation is the higher you implant the valve, the lower the pacemaker rate, the higher the risk of embolization, and the higher the risk of perivalvular leak. And in this case, we're seeing some embolizations. I don't know if 4 embolizations is a lot, but it's certainly more than I would like to see. But we're not seeing any signal in terms of perivalvular leak. And that to me is unexpected. I would expect that the higher you implant, the lower the pacemaker, the higher the perivalvular leak, and we're not seeing that.
yeah. Oh, absolutely.
Yeah. And I think that Andre make a good point in the sense that by trying to oversize as much as possible, it may be good initially because you have generally better hemodynamics, lower gradients, and maybe somewhat less PVL as well. But in the other end, you may pay the price in the longer term because, as Andre mentioned, this oversized valve may be less optimally expanded, maybe underexpanded. So you may have some pinwheeling effect on the leaflets, so mechanical stress, and then in the longer term, this valve may eventually fail earlier. I mean, this is our experience too. So, yeah. So, if we go on to some more statistical consideration, I think it's more theoretical, but I think it's important to also have this in mind. Again, there was 2 primary endpoints. The first one, the clinical, was powered for non-inferiority, and with 85% power. And also, and the co-primary endpoint number 2, the bioprosthetic valve dysfunction, was powered for superiority. And actually, this looks trivial, but it's important. I mean, non-inferiority trials are designed to determine whether it can be ruled out that the efficacy of an experimental treatment, and the experimental treatment in the context of the small annulus will be the self-expanding, is unacceptably worse than that of the active comparator, that is the standard of care, and that would be, in this example, the balloon expandable valve. And this is done by ruling out a proper non-inferiority margin. So the first thing is that when you have non-inferiority trial, it is very important that the two arms are very well balanced and both optimally and equivalently delivered. And as we just discussed, there might be some unbalance in the delivery of these two cares, if you will, with maybe a difference in optimal sizing, optimal implantation in self-expanding versus balloon expandable. So this is a first weakness, you may say. The other thing is it is very critical to use a non-inferiority margin that is clinically acceptable. And this is certainly not the case in SMART, because the safety, the non-inferiority margin was an absolute difference, an absolute increase of 8%. Wow. So that's a lot. I mean, a proper margin would have been more 4%, especially given the estimated event rate that was 16%. 4% is already clinically meaningful. And of course, when you lower the bar for the safety margin, you need less patient to demonstrate the non-inferiority. So you need it's a smaller trial and not as much money and effort, for sure. But on the other end, it is more less powerful and robust. And actually, if you the non-inferiority analysis in SMART was powered, as I said, and an estimation that would be 16% event rate, so about 112 events. But unfortunately, or fortunately for the patient, but there were much less events than expected. It was more about 9-10%, so 71 events in total. So was definitely not powered to demonstrate non-inferiority. And if you would have used a proper non-inferiority margin of 4% with robust stats method, you would have needed maybe more than 250 events to make the demonstration. So we are far from the 71 events. So just meaning that even for the co-primary endpoint, the non-inferiority was not well designed and not well powered, and so some senior statisticians say, well, that the SMART trial cannot claim that they are non-inferior. So this is important, because if you do not pass non-inferiority, you cannot test for superiority for primary endpoint 1, but theoretically, according to the protocol, they could not have also tested superiority for co-primary endpoint number 2. So they should not have been allowed to report the p-values. So I think it's important. The other very important point is the definition, and maybe to me the most misleading aspect of the SMART trial. This is the definition of the bioprosthetic valve dysfunction endpoint, is BVD. And so clearly there is a difference in this rate of BVD through 12 months. And I have to confess, I was expecting a difference using the definition that was used, but maybe not as much difference. So it's 9.4% in the Evolute versus 41.6% in the Sapien. And of course, saying or concluding that you have about 42% of the Sapien valve that are dysfunctional at 1 year is certainly worrying. Is it true? No, but still, I mean, the message is out there. So, and when you look at the definition, again, it's a composite. And one is a non-structural dysfunction, and it contributes for the difference because essentially you have more severe mismatch in the Sapien versus the Evolute. But most of this difference between the group is related to this hemodynamic, what they call, and that I think was unfortunate, hemodynamic structural valve dysfunction. That was tenfold higher in balloon expandable versus self-expanding. So you're saying, that 32%, so 1/3 of the Sapien valve are structurally dysfunction. They have structurally dysfunction, which means that they will probably be less durable. However, this endpoint was defined, again, remember, on a definition was a mean gradient more than 20 at any echo. And in fact, a mean gradient more than 20 is not a marker for structural dysfunction. It's a marker for non-structural dysfunction. It's just another consequence of mismatch, okay? So So I think this is a potentially misleading message, especially because if you look, for example, the PARTNER 3 trial 5-year data that we reported recently, the rate of true actual structural valve dysfunction at 1 year was around, was 0% in both arms versus 32% in SMART. So there is something wrong, obviously. And at 5 years, the rate of structural dysfunction was actually, very low, also less than 5%, and similar in TAVR versus SAVR. So the explanation is in the definition. Everything is definition. So you have non-structural dysfunction, and this includes severe mismatch, and this includes the consequence of severe mismatch, which is high residual gradient, which is its mean gradient more than 20. You have paravalvular leak, and then you have the structural dysfunction. The structural dysfunction, this implies that you have intrinsic permanent changes to the structure of the leaflets, and then you have this morphological deterioration that leads to hemodynamic valve deterioration. So you see a deterioration in hemodynamics during follow-up, stage 2 or 3, moderate or severe, okay? Eventually leading to bioprosthetic valve failure. And so this is the definition of non-structural dysfunction that was actually what was included in the bioprosthetic valve definition of SMART, so severe mismatch and high residual gradient and HOR. And you may say, okay, still, even if this high residual gradient more than 20 is not a proper definition and not validation of structural dysfunction, this is non-structural dysfunction, and it may still be clinically relevant. So in this regard, it is interesting to look at this analysis of the TVT registry. That is an analysis of a very large number. That's the balloon expandable 20 or 23. So it's really small annulus, similar to the population of the balloon expandable valve harm in the SMART. And you see that there is an association between the residual gradient and mortality, but it is not what we would have expected. The group that has increased risk of mortality is the group with very low gradient. The clever idea in this analysis that was led by Amer Abbas was to separate the patient into 3 groups instead of doing the less than 20, more than 20, and depending on the studies, you show association. Some other studies found no association. Some studies showed an inverted association. They did 3 groups. The very low gradient, less than 10 millimeters of mercury, have substantially increased risk of mortality. And then the other group, the intermediate gradient between 10 and 30, vast majority of the patient, no increase in mortality. And those with very high gradient, so more than 30 millimeters of mercury, not 20, very few patients, they have some trend in increase in mortality, but it's not significant. And you may say, well, this is bizarre. Why very low gradient is associated with increased mortality? Because we always have to remember that a gradient is a marker of prosthesis-patient mismatch or bioprosthetic valve stenosis, but it is also highly flow dependent. It's a squared function of flow. So indirectly or directly, it's a marker of LV systolic function, of LV pump function. And in this group with very low gradient, you had higher proportion of patients with low LVEF, low flow state. So a very low gradient is not necessarily a good news, And by the way, if you have a severe valve stenosis with a very high gradient, as I always say to my fellow, and you die, your gradient will be back to normal, will be perfectly normal, will be very low, will be 0, because there is no more flow across the valve. You see, so the gradient is also, and maybe more importantly, an expression of the function. And this slide again is from this TVT registry that I think is in press currently, but they classified, the factors that were associated with 3-year all-cause mortality. Of course, the SMART trial does not have yet the 3-year all-cause mortality, but they hypothesized that the bioprosthetic valve dysfunction definition that they have, and that is much more prevalent in the balloon expandable, will be associated with increased risk of mortality at 3, 5 years, etc. But if you look at this data, it's not sure, because you see the most important factor, not surprisingly, PVL. moderate or severe. We know it's bad. Across all studies with balloon expandable, self-expanding, when you have moderate or severe, mortality is increased at 2 years, 3 years, and beyond. Then the second risk factor, most important risk factor, is the mean gradient at discharge, but not high gradient, very low gradient, interestingly. Then you have new permanent pacemaker. So a permanent pacemaker is not necessarily benign. Across all studies, you don't see the impact in the short term, but when you get to beyond 3 years, 5 years, you start to see the impact in mortality. Then you have the very high gradient that comes like next, but not with a cut point of 20, but with a cut point of 30, a real high gradient, And then you have mild PVL, not to be forgotten. I think we often tend to, underestimate mild PVL, but still, mild PVL, they have an impact. It is milder than moderate or severe, but it is there, you see. So yeah, I think it's important to go back to the accurate definition of structural dysfunction. And we've been very careful in VARC-3 to really state the criteria. You need morphological deterioration. You need abnormal leaflets. Most of the structural dysfunction that were in SMART, I'm sure I didn't see the echo, but the valve leaflets were normal. It was just mismatch. It was not structural dysfunction, right? And then you need to document deterioration. But the deterioration is not an gradient more than 20. It's an increase in gradient during follow-up with concomitant decrease in AOA. And we define this very precisely in VARC-3. And why is it important? This is maybe the slide that is one of the most important here, because it shows how the definition that you use can completely change the results in the conclusion. If you use the European definition is the one that has been used in SMART. So this includes this criteria of mean gradient more than 20 at any echo, okay? Then, and you apply this to, there is a little shift in the numbers, but you can still see, if you apply to the core valve high-risk pivotal trial, so TAVR versus SAVR, TAVR self-expanding versus SAVR, SAVR is in blue. You would conclude that the rate of structural dysfunction, moderate or severe at 5 years, is 24% in SAVR, which looks very high, right? You ask to any surgeon with a contemporary SAVR series, it's not true that you have one patient out of 4 that has significant structural dysfunction at 5 years, maybe at 10 years, but not at 5 years. But it's a win for TAVR because TAVR it's only around a bit more than 9%. But that's with the European definition, the definition that has been used in SMART. And that is because in the SAVR, you have more mismatch, more high residual gradient. And these patients with non-structural dysfunction, because of this definition, they were wrongly misclassified as structural dysfunction. But if you use the actual definition, okay, the animation doesn't work on my slide, but maybe we can not see it on the slides because the animation are not working. But what I wanted to show next is that if you use the VARC-3, the rates are much lower, it would be around 6-7%, and they are perfectly similar and the same in the two arms. And if you look at reintervention, there was actually numerically more reintervention, 2-3% in TAVR versus about 1% in SAVR. So you see that it makes a world difference. And I think the same applies to the SMART. I think many of the non-structural dysfunction were misclassified as structural dysfunction, but it's not, okay, because it's just high residual gradient. So this is a summary of the this is taken from the I think the deep dive presentation by Howard Ehrman, and yeah, they make this hypothesis that the large difference observed in valve performance. Interestingly, here it's not called anymore bioprosthetic valve dysfunction, but valve performance. There is a little bit more caution in the way because this is what it is. The high gradient and the mismatch is more valve performance than dysfunction per se. They believe it will impact longer term performance. Maybe, but we don't know. And I think according to what I showed and the absence of impact of the gradient and also the mismatch in the TVT analysis on clinical outcomes at 3 years and beyond, it is not sure that despite the difference in the bioprosthetic valve definition used in SMART at 1 year, that will see some difference in clinical outcomes. There is no difference in clinical outcomes for now, for 1 year. We'll see beyond. But I think, and you know, this last slide I'm showing here, I think summarize my view, and I think Andre share some of this view. But what we should do now, because I think for the clinician we're treating patients and we're listening to us, I think we have to tell what are the implications of the SMART trial. To me, for now, the SMART trial has no implication with regards to management of the patient, because there are some evidence already that TAVR may be preferred to SAVR in the small annulus population, and also therefore the women, because women, small annulus, you know, there is a very important common denominator. There are some data suggesting that, yeah, in this population, TAVR is maybe better and superior to SAVR. Regarding to now, if let's say you decided to do a TAVR, is there a difference between balloon expandable and self-expanding in the small annulus / women population? In terms of clinical outcomes, no, absolutely no difference. But there are some difference, let's say in this secondary endpoint with more mismatch, high residual gradient obviously in balloon expandable, that was responsible for this difference in bioprosthetic valve dysfunction at 1 year in SMART. But in counterpart, you have more technical failure. You know, there were more embolization in SMART and crossover to balloon expandable. Technical failure is not a good outcome, right? And more PVL, not in SMART, but in other trials and registries, and more pacemakers that may have an impact on clinical outcomes in the self-expanding. So in the longer term, who will win? We don't know. But for now, there is no evidence that one is better than the other. So I think we have to wait for longer follow-up, of course, in SMART. And in also Lytton trial. Lytton trial is also a balloon expandable versus self-expanding, but in the valve-in-valve, within failed bioprosthetic valve. So it's really the epitome of small annulus. And to see if there is differences eventually in clinical outcomes in the long term. And one thing I'm particularly interested to look at is, will there be any difference in the durability, valve durability between the two platforms in the small annulus? We don't know. We have to wait. And there are two other very important trials that everybody needs to keep an eye on. One is the REA trial. The REA trial is not a TAVR balloon expandable versus self-expanding, but it's more a TAVR versus SAVR in women only. So it's small annulus, women. So, but it's going to be interesting. So it's really TAVR with the balloon expandable valve, the SAPIEN 3, etc., versus SAVR. And we'll see. I mean, the primary endpoint is at 1 year. We plan to present the results of the REA trial at ESC 2024, so soon. And the best trial is a balloon expandable versus self-expanding TAVR in all comers. So it's not only the small annulus. It's a pragmatic trial conducted in France, national trial, and close to 2,000 patients. I have the pleasure to be a co-PI of this trial with Eric Van Bel from the CHU of Lille. And to my surprise, I would say the recruitment is progressing very well. I think will be done by the end of the year. And the primary endpoint is clinical, so it's really mortality, stroke. But of course, we'll also report the severe mismatch, the residual gradient, and the PVL and the pacemaker. And we should be able to present the results during the 2025 year. So this is, I think, what we can say from the SMART trial and its implication.
The soap opera continues. And so, Andre, what are your thoughts on this data that Philippe's presenting? Philippe, that was great. That was really a tour de force of the trial. I wasn't aware of the non-inferiority margin that they had included in this trial. And so, Andre, what are your thoughts?
I was not aware. I was not aware either. But this issue has been brought to me by some, key seniors who say, "Oh, there is a problem in the SMART trial." So, and they explain why. But so I'm just repeating what I've been told by experts.
So what I struggle with is, I mean, the one thing that to me is a concern is that the KCCQ measure, which should be relatively objective, is different at 1 year, and that one I cannot wrap my head around. But there are so many outliers in terms of stroke, in terms of PVL, in terms of pacemaker rate, that I am concerned about the reproducibility of this data, because as we know, in research you can have the best data. If it's not reproducible, it's not worth the paper it's written on. So I think that's why it's important to look at the studies that Phillipe mentioned, and I think we'll know more as time passes, and it's going to be interesting to see if the durability data actually gets published, at 3 years, at 5 years, to see if the objective data gets published. And on top of that, it will be very important to see why valves, if there is valve deterioration, to see the criteria that are applied to valve replacement. Because if I take a valve that has a mean gradient on 25 and they say, this valve is degenerated and I want to replace it, that's most of the time not a good idea. I mean, in my mind, for you to replace a valve, the valve has to have evidence of true structural valve deterioration, ideally leaflet calcification on CT or wide open AI in the valve itself. Barring that, you're not doing patients a favor by replacing valves, transcatheter valves early. The other thing, and I brought this up when Phillipe and I talked last time, is as much as this study will not change my practice, high gradients are a nuisance, are a pain in the neck for me. I have 15 minutes to see a patient in clinic. Somebody shows up, their gradient is higher. I have to pull up the echo. I have to look at their stroke volume very carefully. I have to see how they measure the LVOT. They make a measurement error in there. I have to look at the VTI. And if I start ordering additional tests, even if I order an echo at 6 months instead of a year, if I order a CT, if I order a TE, if I do an invasive test, then that affects the patient. So the thing that I think is missing in this whole discussion is, how do we deal with the patients with high gradients, and how do we make sure that in the probably 90-95% of cases where there's really nothing going on, it's just high gradients, how do we exclude significant problems? Because the alternative is not good either. If you have somebody whose gradient is climbing and you say, no, this is fine, and then 6 months or a year later their leaflets are calcified and you have to replace the valve, maybe you missed an opportunity. So Phillipe, what do you look at? How can you tell whether there's a problem or not when the gradient is higher?
No, absolutely. I think, Andre, I think we should do a better job. I mean, the measures to provide to the community, I think, an algorithm, and maybe we should do that with the ASC and other to how to interpret and manage the high gradient. I think, So first, I never look at high gradient in isolation, because a high gradient is not necessarily implies valve dysfunction and matter for concern. Vice versa, as we saw, a low gradient is not necessarily absence of dysfunction and good news. So more than the absolute value of the gradient, I really look at the changes over time, the changes in gradient, and also not only in gradient, because you may have sometime a gradient that increases just because the flow across the valve is increases because the LV function is improving. And so in this case, it's rather good news than the bad news. But you may interpret that, oh my God, the gradient is climbing, and so there might be a progressive stenosis. So it's always important to look at the change in gradient in combination with a change in valve area. I look a lot also to the Doppler velocity index. That is a simplified version of the valve area, but has less issue in terms of measurement error and variability. And I look at the leaflets, and I think this is key in the end. I mean, if you do a good echo, often at TT, you're able to see the leaflets, And but sometimes you have to go for other imaging modality, and of course then it's getting a little bit more difficult because you may have to consider TE or CT. But most of the time with the TTE, a careful TTE, I'm able to tell, with the different views, if the leaflets are normal, moving well, then, I mean, the high gradient is not a worry for me. It's going to be a mismatch. And there are also other ways to measure the mismatch. So obviously, if the gradient is due to a mismatch, stable over time, with leaflets that are morphologically normal, just follow the patient and certainly do not do additional test or reintervention for sure. If there are some abnormality of the leaflets, then I need a more careful follow-up. And in some time, I need to go multimodality imaging, do a TEE or a CT. That is more and more accessible, but that's only in the case where I cannot resolve, and some people say, what about using catheterization, an invasive assessment? To me, it is a bit useless, maybe because I'm a major, I'm biased, I don't know, but the catheterization may be interesting when you do a procedure and you're not sure of the gradient, or the echo telling you there is a high gradient, then it's good to corroborate that with an invasive measurement to confirm if there is or not a high gradient. And if there is, maybe you could consider doing some additional procedures such as balloon dilation or stent fracking if this is a valve in valve, things like that. But for patients who is post TAVI or SAVR and that has some high gradient, eventually noticed an echo, doing a CAT to confirm is not very helpful for two reasons. Because often when the patient goes to the CAT lab, 70% of them, they are in low flow state. So echo may overestimate the gradient, but catheterization may underestimate the gradient because of the low flow state. Second, always remember that the catheter cannot see the leaflets. So you will not be able to do the differential diagnosis. The only thing you can do is say, oh, the gradient is real or not, but that's it. After that, you cannot say if it's due to a mismatch, non-structural dysfunction, or structural dysfunction. And the important thing to finally resolve is this a structural dysfunction or a non-structural? Because this will completely change your approach. If it's a non-structural dysfunction, I would say follow up as usual. No matter to do any additional test. No need to consider any intervention. If it's structural dysfunction, leaflets are abnormal, then it will probably be progressive. It's one way, unfortunately. And so I do not mean that you should intervene now because it's maybe a mild or moderate structural dysfunction, but you need to follow the patient as we do for an ATVS, need to follow the patient. And when the dysfunction becomes severe and or the patient develops symptoms of heart failure, then it's the time to reintervene. But that way, I think, will be more have a better management of the high graded. I'm participating to a trial that is led by David Wood, discordant trial, and the purpose is exactly that. There are patients who have a high gradient on echo, no more than 20 or 30. So there is a suspicion that there might be some structural dysfunction and indication for reintervention. And we do simultaneously, or not, but we do an echo that is read by the core lab, so by us. And there is also an invasive assessment that is done. And I can tell you, maybe it's a scoop, but that in most of the cases I've seen so far, the high gradient were not due to structural dysfunction. They were suspected to be, but they were not. The leaflets were pristine and normal, and this was just, high residual gradient due to mismatch. And so I think in this case, especially if the patient has no symptoms, leave the patient alone, and just follow the patient. I do not mean that some cases of severe mismatch with true high residual gradient may have symptoms and develop heart failure. So although this is non-structural dysfunction, you may still need to reintervene, in such cases. Just as we do for PVL, for example. Non-structural dysfunction sometimes leads to, failure and need for reintervention.
Yeah. Well, dude, I think this is fantastic, Philippe. I think coming back to first principles, whenever you see a new paper come out, the first thing you always want to look at is internal validity. Like, did this test the question that it intended to question? I think the answer to that is there were some flaws, clearly, but long-term follow-up will tell us more. And then really, I think the external validity is the thing that most physicians are really curious about. Can I take the results of this trial and change my own practice? And I think we've brought up some concerns with that. And then just leaving with this note, this is data from the Amtrak trial, and I think this is kind of how I've taken away from this is they basically took eight evolute dominant centers and 5 balloon dominant centers, and they just looked at 2-year outcomes. And you can see when you're very facile with evolute and you have a sense of the nuances, the outcomes in terms of mortality, even pacemaker and stroke were fairly similar, slightly higher stroke rate. But if you're doing a primary balloon expandable valve shop and you're doing a couple hundred TAVRs a year, 100 TAVRs a year, and you try to dabble, I think, in evolute, the outcomes are worse. And I think that the important thing is be good with the valve that you have, know it, and understand the nuances of it. And I think that's one of the problems in externally validating these results is that if you're good at evolute, you're going to have good outcomes. If you're good at sapien, you're going to have good outcomes. But it's kind of hard to be good at both. Is my opinion of that. So I don't know, Andre, what do you think of this data?
Yeah, I think certainly with every device that you're using, you have to be really good at one thing. You can be good at a couple of things, but again, part of the challenge when you're really using a lot of one is that a lot of times people end up using the other device in the cases where it's most difficult to use it.
Yeah, totally.
So that's a problem in medicine across the board, and I think if you have a center that's doing 50% of this, 50% of that, they probably will have better outcomes with either one of the valves than a center that is doing 99% and then uses one every now and then.
Yeah.
I think the whole gradient discussion will not be put to bed anytime soon. The gradient discussion will continue. It is clear that self-expanding valves have lower gradients. What that means, God only knows. We're still waiting for that information. I think the other thing and the elephant in the room here is that the bigger problem is going to be if you take people who have women with very small roots and you put oversized tall frame valves in there and those valves eventually fail, redoing their TAVR is going to be painful, if at all possible. So I think the whole discussion about lifetime management has kind of fallen on the back burner these days. But I think that that's going to be the big deal. And I think that especially as we're looking at younger people, the answer, and we don't have data for this unfortunately yet, but the answer may be some of the smaller valves, especially in bigger people, because sometimes you see, 300 millimeter annulus or 280 millimeter annulus in somebody who's 300 pounds. A lot of those people may actually be better suited for aortic root enlargement, aortic root replacement, that kind of stuff. And unfortunately, the number of surgeons who are capable of talking about aortic root enlargement and replacement is a lot higher than the number of surgeons who are actually able to do those surgeries. So it's we're coming to interesting times, and I don't think this moves the needle definitively, but it's something to keep your eyes on for sure.
Yep. I love it. Well, with that note, thanks, guys. I appreciate you taking the time to talk about this important trial, and I think this was a great discussion. Thank you.
Thank you.
Cool.
Thanks, Phillipe. Bye.